According to the WHO 2023 data, prolonged labor contributes to approximately 60,000 preventable maternal deaths in a year. But there is hope, a life-saving tool to stop this, which is neither expensive nor a high-tech. It is the humble Partograph. Let's be honest, the 90% tutorials on Partograph are boring. But not today. On Love Obstetrics and Gynaecology, we are flipping the script. And I'm going to tell you how a 10-cent Partograph actually prevents the disasters. This deceptively simple sheet acts as a labor detective and identifies the trouble even before it occurs. So it helps us in the monitoring of the progress of labor, identifying the abnormality, and further guiding us in the clinical decision making. Let's break down the Partograph's key components. This single page tool tracks three critical elements. First, the fetal well-being, second, the maternal well-being, and third, the labor progress. The Partograph's key components are your roadmap for safe labor management. Miss one section and you are flying blind. Before we plot a single line, we must get this right. It isn't just a bureaucracy, but the patient's identification is the first safety net. So it includes the name of patient. Write the full name of patient so that we avoid any confusions with the other patient and the chaos along it. Next is the hospital ID number. It is very essential we write that on the top of the Partograph, and we can link this Partograph to her other electronic records. Next is the gestational age, and it should be written in exact weeks. It gives us information about whether the patient is at a term pregnancy or a preterm pregnancy, and we deal accordingly. Next is the obstetric formula or the gravida para of the patient. The parity basically tells us whether she is a multi-gravida patient, multi-paras patient, or a primi-paras patient, and the definition of prolonged labor differs in both of these, and the time allotted to these patients is different. Next we have is the time of admission of the patient and the date and time of admission and the date and time of rupture of membrane. Both should be mentioned. Whether if the membranes are intact, we can keep it, we can write it as intact. This rupture of membrane time is essential so that we can, firstly, of course, we have to give antibiotics to the patient, and next we have to plan further accordingly whether she's a preterm patient or she has developed a chorioamnitis. Rest all depends. And also we have to look for the color of the liquor. Now I would like to suggest three more improvisation in the top data of the patient. The first is it should include the comorbidities. If the patient is having any comorbidity, we can write it simply with a red pen at the side of a paper, on the top of the paper, or at any column along with it. Whether she is hypertensive, diabetic, we should know that. Next is we should also somehow mention whether the patient was booked with us or she just arrived, she had just the first visit with us at the time of delivery. The other thing that I like to say is we should include the last meal, the time of last meal of the patient in these columns. So there is a mnemonic to remember this. For example, that is ID check before the labor. So ID basically includes the patient's name, the hospital number, along with her obstetric formula and gestational age. ID check. C stands for the comorbidities, before, B for the booked status, and labor means her last meal. So a quick question for you. If your patient is both anemic and asthmatic and she goes into labor, what all measures will you take? Now that we have nailed the patient's ID, let's dive into a more critical section of the Partograph, which is the labor progress. It includes the cervical dilatation and the uterine contraction. Along with it, we can consider the fetal head descent and the fetal heart rate. See, the cervical dilatation is the star player. The contractions are a unsung hero, and the fetal heart is basically the whistleblower. Each hour or minute over here can decide whether the patient would land up into a cesarean section or would progress to a vaginal delivery. The first thing that we fill in a partograph after the patient's basic details is the patient's cervicogram. And in this partograph, it starts basically at 4 centimeter. So that means that the patient should be at least dilated 4 centimeter so that we can start with the plotting of the graph. Now let's look at these lines, the alert line and the action line. The alert line begins at the 4 centimeter of dilatation on the exactly on the vertical axis. It is from where it starts, and then it progresses or it goes along as 1 centimeter per hour dilatation. And next line is the action line, which is exactly 4 centimeters across to it on the horizontal axis. And there are various zones in between them. To the left of the alert, we consider it as a very safe zone. Between the alert and the action line, we consider it as a zone where the patient needs a very critical assessment. And if the line or the zone that goes beyond the action line towards the right, we consider that the patient needs active intervention. It can be in the form of either the augmentation of labor, or we might need to perform a cesarean section. The next we have is the fetal head descent. See, the fetal head descent column is directly below the cervicogram. And here we mention the fetal head descent in terms of the per abdominal descent, not the per vaginum assessment. So in the per abdomen assessment, we have a rule that is known as the fifth rule, which means basically the fingers of your palm, that is your forefingers and the thumb, are placed suprapubically and they fully cover the region of the fetal head. This is when we call it as 5/5. That means the head is totally not engaged and it is ballotable. And slowly the head keeps on sinking down to the pelvis, and we have further degrees, that is 4/5, 3/5, 2/5, 1/5 and 0 when it is not palpable. So in this graph that you can see, graph actually starts from 4/5, right? The 4 is mentioned on the vertical axis, and then subsequently till 0 we have the numbering. 4/5 means the head has not engaged, and 5/5 was totally ballotable. The 4/5 actually means that the head has descended down, but still it is not engaged, and the occiput prominence and the sincipital prominence both are very easily palpable. Next, 3/5. 3/5 means the head is just engaged. That means the sinciput can be felt very easily, but the occiput is just felt. Then the 2/5, that is 2 fingers can be accommodated on suprapubically, and this means that the occipital prominence is not at all felt and the sinciput is just felt. And 1/5 means you can just place 1 finger suprapubically and neither the sinciput neither the occiput is felt, and slowly that 1 finger also does not get accommodated. The whole of the head has descended down and it is the 0 station. You can remember it as osci out, that is the occiput gets first engaged and you cannot feel it. Cinci stop, and the sinciput also stops feeling. That is when you can 100% say that the fetal head is engaged. That is the 2/5 head is only palpable. Next, focus on the bar that is exactly below the cervicogram and the fetal descent. It mentions your time in hours. So that one box is equal to 1 hour. And as you can see that this 1 hour is further divided into two columns as we move upwards in the fetal descent column as well as in the cervicograph column. So that means that each line in between those columns represents your 30 minutes. The cervical dilatation is noted at a 4 hours interval. We have to minimize our per vaginum examination so that we can reduce the infection rate. The fetal head descent, that can be noted along with that at a 4-hour interval, or you can go for that even in between the findings, as it is the per abdomen assessment, not a per vaginum assessment. Contractions are the power source for the labor. If too weak, the labor stalls, and if too strong, the baby crashes. The uterine contractions in a patient are assessed by placing a hand over the fundal region. Your palm lays flat on the fundal region, and then you time the contraction on the watch that it was of how much duration, and you time these for at least 10 minutes. That is how many contractions happened over a period of 10 minutes and what was the duration of that contraction. Now let's decode that over the partograph. See, over the partograph, you can see right below the cervicogram and the fetal descent, we have the bar for the uterine contractions, and these are divided into the blocks. The blocks on that vertical axis basically means how many contractions you had in the 10 minutes. And supposedly, if I was measuring the uterine contractions and I assessed that over the period of 10 minutes, the patient was having 3 contractions and those contractions were of less than 20-second duration. What will I do? I will fill the 3 columns with dots, and next I will assess it again over the period of 30 minutes. So in every 30 minutes, you are assessing the uterine contractions for a 10-minute interval. And if supposedly I get moderate contractions, 3 moderate contractions, then I'll be filling my squares, 3 vertical squares with the oblique lines. And supposedly if I get a very good contraction, strong contractions of more than 40-second duration, then I'll be shading whole of those 4 squares, completely filling those 4 squares vertically. Just below the contractions, we have another bar that mentions specifically regarding the use of oxytocin. The oxytocin is very commonly used for the augmentation of labor throughout the world. So that oxytocin, if we are using for the augmentation of labor, it should be documented, and in that we should document at what concentration it is going and at what is the flow rate, how many drops per minute. If you want to learn more on the oxytocin augmentation, you can go to my video on the oxytocin and the labor augmentation protocols. Also below the oxytocin column, we have another column for the drugs and the IV fluids that we are administering the patient, so that we can have overall knowledge about any drug that has been given and how much amount of fluid have we administered. The fetal heart rate is the ultimate whistleblower. It tells us when the baby is thriving or just barely surviving. On the partograph, it is not just a number, it depicts the lifeline of the fetus. So on the partograph, the topmost column is given to the fetal heart rate, and the fetal heart rate is mentioned in beats that you hear per minute, and the fetal heart rate is plotted every 30 minutes. There are 2 horizontal lines which are specially in bold so that we can know that the fetal heart range should remain in between those 2 lines. The lowest limit is at 110 beats per minute and the topmost limit is at 160 beats per minute. That means if your fetal heart dips below it or goes above it, it is a fetal distress. Just below the fetal heart rate monitoring column, we have 2 more columns, that is the amniotic fluid assessment column and the moulding. These also tell us about the fetal status. The amniotic fluid, let's talk about that. The amniotic fluid can have 4 possibilities, so you have to mention it is in the letters. The letters that are used are I, C, B and M. So I basically means the membranes are intact, and if you have ruptured membrane, you have further three possibilities, that is either C, which means the liquor is clear, which is a very good thing. The liquor is clear, that indirectly depicts us that the fetus is having a good time inside the uterus. Now talking about the M and B. M, meconium, or B, blood that can be due to abruption. So these are two conditions where we have to closely monitor the labor if we have a M or B in the column. Now coming on to the moulding. The moulding basically means that the fetal skull bones, they are very soft and pliable, and they can override on each other as the fetus passes along the birth canal, so that they can decrease the fetal head diameter and somehow pass along that birth canal. And it is further of 4 grades: 0, +1, +2 and +3. 0 means that there is no moulding on the fetal head. +1 means that the sutures, the bones, or they meet across the suture but they do not override it. In +2 they override it but they can be separated. In +3 they are permanently overriding and they cannot be separated. So now coming on to this moulding. Moulding is basically a GPS system that tells us how the baby is navigating through the birth canal, whether it is navigating fine or it is going towards the obstructed labor. So how do we mention this moulding on our partograph? See, you can assess the moulding only on a per vaginum examination, and as I mentioned, for the cervicogram we do a per vaginum examination at a 4-hour interval, and same goes for the moulding. So you mention it after every 4 hours, and in case you get a 2+ or a 3+ moulding, then you have to see that case more specifically and not just leave it on a 4-hour interval. Now a very important information regarding this moulding and the caput. See, the caput basically refers to the edema that occurs if the fetal head is stuck at a specific point for a very long time. So the first thing that happens is, as the baby was passing through the birth canal, it stopped somewhere. There was overriding. The fetal head tried to compress itself, right? So there happened some kind of overriding, moulding, and then it stayed for too long, like that. It was stuck in that pelvis, and subsequently your caput develops. There is a soft tissue swelling, the scalp edema that develops right over the presenting part. So if you were first able to assess in a patient moulding was present, and then finally you assessed a caput was forming, that basically indicates that you need to reassess this patient very, very carefully and plan for a possibly operative delivery. Now let's talk about the maternal parameters, especially first the blood pressure and the pulse. The BP and pulse, they aren't just the vital signs. These are the signs that can predict the disaster if ever happens. See, there are a lot of cardiovascular changes during the pregnancy, but they peak around in 3rd trimester during the delivery and just the postpartum. At this time, it is very crucial to keep on assessing the vitals, BP and pulse. So in the BP, we monitor the BP on a 2-hourly basis and pulse at every 30 minutes. Look for the signs of rising BP, especially the diastolic BP. Overall range, it should be at least less than 140/90 millimeters of mercury. And also for the pulse, there is slight tachycardia during the labor, but that tachycardia should remain at least below the 100 beats per minute. And also we look for the temperature. The temperature monitoring is done at a 2-hourly interval. Now let's move on to the last column, that is of the urine analysis. The bottommost column is for the urine analysis, and the urine analysis is done at a 2-hourly interval, where we assess further few things in that. We look for the acetone, the glucose, the protein and the total urine volume, and especially talking about the protein column and the volume column. The protein column, basically one positive, done by the dipstick method, 1 plus or 2 plus positive, points towards your preeclampsia or HELP syndrome. And the urine volume is very important. The urine volume is noted in ml, milliliters, and it basically should be more than 30 ml per hour. So now quickly revising the key components of the partograph. The first thing that we fill is the patient's particulars. Next, we fill the time. It is written in hours at the time of starting the partograph. And the next thing that we fill is directly above that hours is our cervical dilatation and the fetal head descent. We plot the cervical dilatation with the cross and a descent with the O. Next, you fill the fetal heart rate and it is recorded every 30 minutes. Below that is the Liker, amniotic fluid column and the Moulding column. Then let's go down below more where we have the uterine contraction column that has to be shaded accordingly, and finally the maternal columns, the amount of drug that we have been giving, the oxytocin or whether any other drug, the fluid that has been administered, the vitals, the blood pressure, pulse, temperature, and finally the urine analysis. Thanks for joining me on the channel Love Obstetrics and Gynaecology. Please do like, subscribe and share this video, and also comment on your queries regarding the partograph and your personal experiences regarding the partograph, and see you in the next video. Thanks for watching.